Check, check, check. Thank you. Okay, let's see how this looks. Nice. Nice. Yeah, good. Edit that. Okay. We'll edit that. Sorry, Barry. Okay. Fluffy woman. Good morning, Corey. Can you hear me okay? Hello? Check, check, check. Good morning. Can you hear me? Hello? Check, check, check. Hello? Can you hear me?
I can hear you.
Okay, great. Thank you. I just wanted to make sure.
Hey, Barry.
Hey, Corey.
Hey, I had a run on Thursday. If you ever get a chance to look at it, will you?
You had a run on Thursday?
Yeah.
Can you?
The address was Jackson Boulevard. It's like 1 Jackson Boulevard.
Okay, and that was on Thursday, which would be what, 6?
I don't remember the date. What's today?
8.
13.
Thursday, the 8th.
Yeah,
Okay.
it's pretty crazy.
All right, I'll read the report, look at it. Are you there with anybody else?
No, it's just me right now listening to it.
Okay, well, this is going to be the advisory meeting. Can you mind logging off and come back in at 9?
Oh yeah, no problem.
Thanks, man. Hey,
Yep.
do you happen to know that patient's name?
Yeah, I had it pulled up a little bit ago. It was Lynn something.
Hey, text it to me.
Okay.
Yeah.
All right, I got
Date of birth and the last name's all I need.
you. Okay.
Thanks, man.
Yep.
Sorry about that. I appreciate it.
Yep, no problem.
Hey, Jeremy.
Morning. I was sending you a text.
All right. I got you.
I'm gonna give you a call later on today to have you sign up for the AEMT practical.
Oh, okay.
So
When are you guys hosting it?
July. And it's going to be, it's either the 31st,
The what?
30th, July 30th. Yeah.
Sunday the 30th?
What's that?
Sunday the 30th?
Correct, sir.
All right, I'll put it in my calendar so I don't forget.
Okay.
How many you guys got?
10 right now.
Oh, good.
With the potential of some outsiders.
Sure.
Would that be you or will it be somebody else?
That you need to put it in for me to do it. You need to request me on National Registry.
But you guys are the ALS training institution portion.
All right, I will go in and do it.
Okay.
Yeah, I mean, yeah, I should be able to do it.
Okay, sounds good.
We'll figure it out. So, yeah, I'll put it in. I don't know if they'll let me do it or not if I'm a training institution. Should be able to, but since I've not taught the class or did anything with it, who knows?
Right. I don't feel there's any conflict.
Not at all. I haven't done one single thing with anybody, so on it. You at station today?
No, I'm at Ivy Tech for medic class.
Okay. I got your winter. No one came and got that last week. I thought Diane was coming to pick that up last week.
You know what? I'll send her a text today. I'll have her come up there.
Okay. Yeah. I've got to leave around 2 to go do an education out off campus, so she can come before 2. That'd be good.
Okay. I'll send her a text right now and let her know.
Thanks.
I'm early, Council.
You are. Sign in. I'm scared. You're 2 minutes early. Actually, you're about 5 minutes early because usually about 5 after.
I would have been here earlier.
Huh?
Well, my neighbor had me up at 4:30 and then didn't want to go to the hospital. I said, you woke me up at 4:30, you're going to the hospital.
Yeah. I'll have that occasionally.
That seems fair.
I would agree with that,
He's
yeah.
up, everybody's up.
Huh?
Bill used to say, if I'm up, everybody's up. Come on, let's party.
Well,
Get the coffee ready.
Right.
he's our new frequent flyer, is my friend's dad.
I only have 3 neighbors.
Yeah.
So I'm good.
Well, my neighbor, he's.
And my immediate neighbor's in South Carolina right now, so.
My neighbors are in-laws. They call me to go to the hospital. They're gone.
Yeah, I will not text you.
He didn't say when.
Right. I was just having a hard time believing you. You just never know.
Yeah, no.
You sign in for me, please.
They come in the back hall and go, hey, Dr. Mullen here. We're like, I don't know, ask Alec.
And Alec is no,
His days are numbered.
how many more days has he got left?
2 weeks, just exactly 2 weeks.
I refuse to acknowledge it, so. Hey, yeah, he's gonna. Right, exactly. what
You know, if you
does
quit
well.
punching the misses
If you
like
have
that, that wouldn't
replacement,
hurt
right?
you. I know that, right?
Or you're sick.
Shit, if he punches misses like that, that would be the least.
Well, yeah, yeah, broken other things.
Trust me. I just can't stand on my own 2
Spoiled
feet.
by
I know
Alec.
most of the misses, that wouldn't hurt. I know most of the misses, and that would hurt.
Yeah,
Is he does so many little,
how bad they say it was.
when you put them together.
You operate on it.
Oh, yeah.
That's what I thought.
Right.
Yeah.
And 3 weeks ago, I
So-
stepped on my pool cover on the driveway.
Yeah.
Ensure that somebody's gonna be there to make sure those walls.
And he does it like.
I had the MRI last Friday. I see Ortho Indy again Thursday.
You guys are good.
See how bad I tore it up,
But the advantage is he's not going.
but it crunched when I hit the chimney.
So, but the good thing is, his previous practice coordinator.
My kid got hurt.
Yeah.
I'll sign the application.
I was gonna get it very.
I'm just being nice, so you don't have to get up.
Thank you.
I think he's trying to help.
Yeah.
Well, you snagged your, or my Tony snagged her.
We saw a doc that used to be an ortho doctor. I said, I remember that guy's name. He's got an office up on 106, off 106 and 31.
I usually go to Brownsburg.
It's like you expect her to
It's
show up
closer.
and do episode.
Right.
When they did my knee, I went to Greenwood.
Yeah, this is up off of, by the heart hospital, like just like, it's on the opposite side of the road, down in the woods there a little bit.
It sure is.
Yeah.
That's a weird name and I can't think of it.
If they're
I'm getting ready to retire. He's not a
It's all
like
like
a Hindu or anything like that. He's
like
like German.
Oh, really?
I cannot think of his name, doggone it.
just the tabulation of data alone.
He's, my kid dislocated his kneecap playing Olympic force cup ping pong one night after school for basketball game. I'm like, oh, great. You can jump with him. But he, I think he is or used to be affiliated with it. George, not bringing it up.
We got all our CME stuff in, do you know, I haven't talked to Kale about it recently.
What they asked us for, we're good.
Okay.
I wouldn't worry about it any further.
Are you in and out of the office right now, or what are you doing?
No, I'm in the office.
Need to-
I can still type.
And then you do.
We talking about setting up some time. I gotta-
Yeah, I was hoping you were gonna be here. Shane's gonna be out of
Still
town
blows my mind that all that's not. just-
Friday. I'm gonna be gone Thursday.
So if you do.
So we'll probably have to bump it to
Regular,
next week.
university,
That's fine. I will be out of the, I gotta go to a national beta with Logan. I'll leave Friday morning and I'll be, I won't be in Friday and I won't be in Monday, Tuesday, back Wednesday, Thursday, Friday. I gotta check with
From there,
Mark.
some of it's
Mark's the one driving that train right now.
ASAP or somebody else that does.
You
it.
He never gave me any dates.
He did, but it was this week. What I'll do is I'll start an email chain if you don't mind. And I know that's annoying, but
Nah, it is what it is.
So like
I like text messages myself.
Literally,
But
every time.
if I start an email chain, then I can CC him and Maggie Waller.
So I-
And then we'll have something next week.
I know it's after 8, but we don't have a whole lot to talk about, and I got a couple people text are trying to get on.
Okay, fine. And then I keep that spreadsheet so that I can tell you. what
Yeah.
I'm
So in other words, we need to shut up.
Not at all. Oh, I'll let you know. I learned from the best on that.
It actually gives you CME credit. I just submitted, I just went, but it's every time you look up something, it's half credit. So when I just did my reaccreditation for,
I feel like you've done
thing.
a billion of them.
right, well,
Bad kid in class is a good kid sitting over here.
Wow, you're here, so you can actually call me over to the office and get your. Yes, I can, yeah. I'll tell Jeremy.
I get back there about 10 o'clock or so. I'll see.
Hey, Jeremy.
We'll start that process, figure it out.
did you look this up for treatment?
Yes, sir.
Matt McCall is here, so he can just come on over to my office and get that stuff.
Okay, I'll let Diana know.
Yeah, tell her she doesn't need to make a special trip.
Okay.
Thank you.
Like, did this change your treatment, did it reinforce your treatment plan, did it not do anything for you? So for some reason, but I did click off.
Most
Good
of
morning,
mine
Josh.
is like, Whatever the presentation is, and then there's like, sometimes it's quiz, sometimes it's not,
Right.
depends on what you're on. And then you always have to do a survey, and then
Right.
that survey is like that,
Yep, but
like,
it's
did this
one
increase
for-
your knowledge?
Right.
And then it gives you this.
Right.
Okay, we're gonna go ahead and get started now. Good morning, everybody. June 13th, 8 AM, advisory committee meeting. Probably is going to be a pretty short meeting, to be honest with you. The old business, of course, is protocol updates. Jeremy, is there anything out there outstanding right this second?
I don't have anything at this time that's outstanding.
I didn't either. Anybody in the room know of anything that's hanging out there? I didn't think there was. I thought we were actually
I think so.
about where we need to be at this very second. All right, so, yeah. RSI testing. Yes.
Yes, what do we decide, the first week of for second week of September? What was it?
No, that's the.
The testing, I will have dates soon for you.
All right, so here's the deal, just so everybody knows, and you can pass this along to everyone, we are going to do 2 4-hour days in Park County to catch Park County, Ileana. We've done it in Ileana last time, and now Ileana can come to Park County and do theirs up there. And then we'll come to Terre Haute, and we'll either do them here, we could do 2 or 3 days here, maybe at the fire department, and then we'll probably do a couple days down there. So I'm looking for 6 days from you.
The end of this week, I will promise.
6
I will
4-hour
promise
days.
For it, promise.
And then if they conflict with me, I'll let you know. But anyway, so
I have to put reminders.
You look
for
at me when you get those days.
I will get the
Okay.
days.
Yeah.
When I get the days, and I
And
will
we can
pick
host a couple.
2 days in Park County, probably 2 days at the fire department, and 2 days down at regional. That'll be, everybody can come when their days work for them. I mean, if they're, like that, so that works out pretty well. 6 days may not be enough, but it's a way to start through the summer. Maybe we start it sometime middle to end of July, run it through August, and then skills days kicks up. Might be able to pick some stuff up around skills days too, if we got an extra, if Malama happens to be available, we might just throw an extra room in there just to do some RSI test outs for stragglers, people that didn't get
In
fit.
my calendar, by Friday at 2 PM, you'll have it.
Okay.
If not,
If not, you owe me a dinner.
there you go, you got it.
Hey, Barry,
Yeah,
I currently have a medic class that finishes this December. Would you want them to attempt to get in now or wait until potentially later in the year times?
let's wait till later in the year for them and then get them. Matt will do one just specifically for that class.
Okay,
We can run down to, he and I can run down to Ivy Check one day and we'll just do a 4-hour, we'll do it there.
sounds good.
So with that RSI testing, there will be a new test. Matt's gonna create a new test. If there's a new module or anything ahead of time, I'll get that out to everybody as soon as possible, so that all the medics can start studying that module. All the tests, of course, will come from the module, then, the skills, how that works. You're gonna take the written test, score, I think, at least 80% is what we talked about. I think that's where it was before, 80%, bless you, 80%, and then test out with one of the medical directors. I'm hoping to get Zach back on board so we can get that, if we can run 2 of them both in one day, man, we can knock some people out that way. So we'll see, because there'll be a lot coming from you guys. I don't know if we can do everybody in 2 4-hour days. Might have to do 3 and bring medics in on the shifts and whatever the case is. And
Then we
then
want to reach out to Dr. Worley and see if he wants to do some separate dates, separate from what.
that would be awesome. That would be amazing.
Please
Please do that.
Sure, no problem.
Because I'm not trying to put it all on Matt, but
Please,
Yeah,
absolutely. If we have both of us here, it makes it go so much faster.
I honestly have made it, we did have to try to re-engage him a little bit. I said,
okay.
he likes that.
So I like to say, I don't want to put it all on Matt, but Matt's here. So,
Absolutely.
and he is the medical director also. So that, He loves it.
It's just, I just work.
So any questions on RSI test outs? Every paramedic in the system has to do it this year unless they had met the criteria that was preset. I believe that's 8 RSIs in the last 2 years. If you met that criteria, all successful, they did not have to retest. If in 2 years, if you're RSI and 8 people, that's a lot of work. So kudos to you. If it works, great for you. Maybe. Anyway, so I'm one of those less is best kind of person. Yeah, I learned that a long time, like 30-something years.
Well, that's also been the trend, right? I mean, with the advent of CPAP, 5PAP and
And
iGel,
it took that
do
away.
you really need to intubate as much? It's the same.
No, and no, I think it's taken it a lot away. I do, and I kind of, I lean towards taking it away. A lot less chance of, sometimes people need an airway.
Exactly.
I would never, a definitive airway is the king for everything, but you can still do a definitive airway with an iGel. If you're moving good air and got good entitled CO2, what, if I was a paramedic, I wouldn't pull it. That's just me. If I pulled up on seeing somebody had an iGel and I got good capnography, if you pull that, that's shame on you as a medic. I'm sorry, that's just me. So anyway, that's RSI test out. So 6 or 7 days. The reason I say that 3 of the days will probably need to be
Just for
3 shift days for them guys, because they have the bulk of all the paramedics anyway, but you guys have quite a few that will. And if you want us to come to your place and do them, regional, whatever's easiest, you guys just, we'll work that out, okay? But Matt's gonna give me 6, 7 days. We can go ahead and get some days from Worley and get him down that way. If we have Worley do some down there and catch South End people, Transcare people up north, catch all Park County, Ileana. Yeah, we should be able to get everybody in, so.
Probably. I'm hopeful that maybe I can, do you want to split up like two and two, like maybe like 2 in July, 2 in August, 2 in September? Or,
Yeah, we might be, if that works best for you.
or maybe 3 and 3, like August and September.
Yeah, if we did 3 and 3. Yeah.
I'll send you a bunch of dates.
Yeah, just send me
Tell me.
what you can do.
Yeah.
And I will plug them in.
That works.
Because I mean,
Okay.
it really not try, I mean, it all boils down to your days.
Sure.
When
No,
you're
no,
available.
understandable.
We cannot do this process. If Zach's not involved, we can't do this process without you. So.
Sure. No, absolutely. No, I'll get you.
So it all hinges
I'll
on.
just reach out and try to get something July, August, September.
Sure.
And say, hey, I got this 3-month range. What should we do?
Surely he can throw it in there.
Oh, I'm sure.
So any other questions on RSI testing? Okay, I have EMS skills days. Again, that is the September after Labor Day. So it's Tuesday, Wednesday, Thursday, Friday from 9 to noon, all 4 days. I do truly need. I know, Matt, you said you would help. I know you would help, and you'll probably come up and can be up there that day. And
Oh, yeah.
I want to facilitate the people going through and not have to do a station myself. If you can run up there, Matt, and visit, that'd be perfect.
Yep, I have my calendar, so.
Yeah, I mean, any one of the days you want to come up, that'd be great. Jackie, if you're welcome, we could absolutely use as many. I just want to be the person that says, okay, guys, sign here, fill in here, that way, and I can get a sign-in sheets and we can keep track of, because we have to input everybody into the Rick Simulation Center, so they can get they get counted. When they get to a million people, it helps with grant money for them. So we want to make sure that they're getting in. So James Harris has already worked on some scenarios for us. If you guys have any ideas of anything you would like, there's not a whole lot of new updates that we did that hasn't already been talked about. So
Do you have a list of the simulations?
I can get them.
Yeah, you can.
Yeah,
I'll send some ideas that I did.
that'd be perfect.
Could be.
Yeah, that'd be perfect. Yeah. Because what we try to do is we try to do some type of a trauma, some type of a medical, some type of a cardiac arrest situation. And if you actually really think about it, you can look at your skills list for every EMT and paramedic, and that covers everything for 2 years. They get it in a half hour, it's skills day. So if Terrell Fire Department sends up everybody, the first 4 companies at this time, and the next 4 companies at this time, we have it done in 3 hours, 9 to noon. Same, you guys used to come up as minute you can. We've had we don't get a lot from Park County, Ileana, because it's up there, but it's here for them. It's always been, it's been advertised now for it's gonna be like 5 or 6 months ahead of time, right? Sometimes we'll even get people from Marshall, when they were part of our group, come over and do the skills days, just to get their skills in. Some of those skills, and we could set up not just skill stations, we could go to the skills room and set up, they can do needle decompressions and practice things like that, things that are, high intensity, low frequency skills. Sometimes we even have the birthing. If we have a lady from OB, she'll come and help, and they'll turn on Noel, and they'll have delivering babies too, so they get that aspect of OB in there too, so. We'll try to figure it out. What I got for you, I'll get it to you, so you can take a look. If you want to add some, that'd be great. So, but that, we're just trying to cover, and I will actually send you the skill sheets for the medics and the EMTs.
Okay.
So you can look at the skills that have to be done.
Right.
And how we can incorporate them in 3 stations, 3 or 4 stations. If we do it in 3 stations, then I know I've got 3 people that can sit in and cover a station. Be the facilitator, not really an evaluator, just a facilitator, putting them through, talk it through. When I was doing them, I would we'd get through, let them run the scenario, then we just sit and brainstorm for minutes because that's what they do, is they just move as a group. Engines 3 shows up, engine 3 goes to all 3 stations, so does that make sense? So that's what you do, and medic, whatever, it's just the way it's always been done. And a lot of people come on their day off because they come knock it off, get a half, they get 4 hours and get all their skills done, so. Any other questions on skills days? Thoughts, processes, please email me, let me know. Jeremy, Josh, you guys got any thoughts?
I don't mind helping out during that time period, and also I can see if I've been sending that out to our people as well, to let them know if they want to try to get up there to get their skills.
That'd be amazing to see some other people to join in and be a part of this too, because it'd be great for the community. let everybody know that EMS in Vigo County is helping. I think puts us out there in a pretty good light. So, anything else, Jeremy?
I have something for new business, but that's it.
Okay. Well, we're gonna cover urology coverage. I'm gonna let Dr. Malaman talk about that a little bit, and then we'll get your new business.
Okay.
We sent that email out, but unfortunately, because of, so at Union here, we had 3 urologists, 1 retired, and another person is at a point based on our bylaws, doesn't really need to be on call. That left us kind of with really 1 active urologist for the hospital. Being able to be constantly on call and do your practice and come to the hospital just was infeasible from a general perspective. So in essence, what happened was that we made it where, well, I didn't make it, it was a decision from higher ups, that they didn't have to be on call unless it's for their specific patient, which then puts us in a predicament when you have somebody who has of emergent natures, the stuff that EMS can truly kind of play a major role in is, for example, testicular torsion. So if we get called for, hey, I've got testicular pain, I've got scrotal pain, I've got acute onset, testicular pain, any of those types of things, or if really any testicular injury or trauma or anything along those lines. Sadly, if they come to us, and it's not to say that we'll ever turn them away, right? We will see them no matter what. But if they come to us, it will almost 100% definitively mean that if there's something acute there, they'll have to get transferred, which means delay in care. And as much as like when we think of stroke and we think of STEMIs, that time is muscle, time is brain, time is testicle, right? And since you only got 2 of them, if you have them and you want to keep both of them most of your life, right? We want to try and expedite that care for those patients. So my philosophy is this, is if you get called out for someone who has a complaint of testicular pain, scrotal pain, or testicular trauma, scrotal trauma, any of those types of things, I would prefer for them to go to regional, since regional has Shanks, has Dave right now, and so has acute immediate care for that patient, versus them coming to us and then us having to retransfer to either regional or down the line. So if we can put that out to the team, just again, it's not to say we'll never turn them away. But if we want to get them definitive care, similar to like if there's a level 1 trauma center and then there's a rinky dink kind of freestanding ED, let's go to level 1 trauma center for major traumas, right? Besides, extremis, et cetera. So that's the philosophy behind urology coverage. You can also kind of spread that out to some other things, but I don't want to get into the weeds of you having to try to figure out who's your urologist, who's not. If like somebody comes in and says, I've got hematuria, or I've got a history of prostate cancer and now I can't pee, or something along those lines. I could ask you to be like, well, do you see a urologist at Union or you don't? But I think that's going to get more complicated for more people, and I don't want to make it that complicated. So I think from because some of those people will have to get transferred to, right? If they've never seen Zahir, they've never seen Tully, they've never seen Schwartz, and they need to be admitted for urologic care, they'll have to get transferred to either regional or down the road. But from the stuff that I think is immediate and acute is the testicular injuries or testicular trauma or testicular pain. Those things I would prefer to go to regional than come to us for now. I'm hopeful that by the end of this year, that should resolve. Okay. Any questions about that? Any thoughts about that? Is that something that we
Just
can
pass it
kind of,
along to your
yeah.
services. That's, yeah. We put the email out. We wanted to mention it again today. And I'll be honest with you, it'll probably get mentioned again in regional as old business. I want it to be moved up into your old business for advisory, and we'll just continue. And if it gets better or changes, or we end up having to get an extra coverage or something like that, we'll make sure everybody's aware of that.
Yep. Yeah, and the minute it changes, I'll send that out. Send something out to Barry, and then we'll send it out to the rest of the team.
All right, I have one more thing for new business, Jeremy, then I'm gonna let you go, okay?
Okay.
So I was called yesterday afternoon. There was an ongoing issue. It has nothing to do with any service that's in this room and or that we are actually in charge of, okay? But there was an issue that came in, and I need you all to spread the word to everybody. If you are bringing in a direct admit and they have a condition change in the fields, the ER needs to know that and see them. Here's what happened. A 70-year-old lady was being transported here and had a change in condition. And the service took her to OBED. And yeah, she was here for Dr. Catino was going to take care of her, so they insisted this patient went to OBED. Well, she showed up at OBED and it's limited. They sent her back, if I'm not mistaken, and it got ugly. And anyway, so please just tell everybody, if they're having a direct admit, come into our facility and there's a condition change, that deterioration, they need to stop in the ER and be seen in the ER. ER then makes a decision, yes, you can go here, yes, you can go there. This particular crew didn't even stop. They were telling me, you need to stop here so we can see this patient, and then nobody have to go to Union, the OBED. It took a 70-year-old to OBED. So I wanted to bring that up, and I will bring it up again in review in front of everybody, but I want to bring it up to you guys as a service. We don't do a whole lot of direct admits, but the thought process is you guys do. Okay, so to me, it's kind of a no-brainer. If they deteriorate, I want to stop and get them definitive care right in front of me as fast as I can. But apparently, this particular crew did not see it that way. That patient was actually coming. I have 100% believe that I think they were taking her to Mother Baby.
Yeah, that's what, yeah. So
She was going to Mother Baby,
Yeah.
which is that direction. And instead of stopping in the ED, they decided, oh, we'll go to OBED. Well, she was 70. She wasn't having a baby.
They even challenged the physician.
They did.
Tried to physically stop them and they went around.
They did, yeah.
Wow.
So it got ugly. So
It got
I'm just
ugly.
telling you now, so please, there's not a 70-year-old that needs to be in Union's OBE for any reason at all, unless we literally, that's where we told you to put them. But so fair enough. All right,
So
I
that's it.
brought it in. So I just want to bring it up because I was asked to, and I told him I would relay it. And then I'm going to say the same thing in the next meeting with if there's more people here on online. So. Okay.
I would say regional be the same way, you know, if you've got a direct admit or you got somebody going upstairs.
Yeah.
No matter what it is, whether it's BHU or anything else, if they deteriorate, something changes drastically, stop, tell us.
I would think so. You would think.
But yeah,
All right, Jeremy, you're up for new business.
Okay, this is a pretty simple one. I've had some EMTs and paramedics approach me asking the question.
Nope.
Okay, fair enough. Nope, that makes it simple and easy. The premise behind it is a couple of them have been dispatched to either Union's ER in the waiting room or Regional's ER waiting room to pick up patients to transfer them to the other hospital because the patient is tired of waiting.
So the patient dialed 911 from the waiting area.
Yes, and I know that at least 2 occurrences, the ambulance services in this county have been so taxed that we now had TransCare going in Terre Haute City to pick up these patients. So obviously the run volume was elevated. So I didn't know if there was some way that we could start, I don't know, talking to the dispatch aspect to say, hey, no, you can't do that. Or if we even have a leg to stand on with that.
I don't think you can refuse them if they call 911.
yeah.
Okay.
That's a big no-no.
That's what I thought.
If somebody contacts 911 and you say you're at a hospital,
Yeah.
and we have no problems with the dispatch center, I don't want to get them in any more trouble.
Yeah.
That's fine. I wanted to present it because I was asked if there was any workaround. So
Yeah, you're at the closest.
No, you're good.
facility.
Yeah.
Yeah, I do appreciate the aggravation of that whole situation. But I'm 100%, there's no way dispatch can say no. And if you're dispatched somewhere, 911, you're kind of gotta go. Now, what you can talk them out of it when you get here, you get that SOR from,
You could be like, the ER doors are right there.
yeah, so,
I was
yeah.
the quickest way is to go down 7th.
Yeah, so I appreciate it, Jeremy. I don't know, and you can probably hear some discussion going on back in the background here, but nothing. Yeah, so.
The
Okay.
misunderstanding among the general public is that you call 911, you go in by ambulance,
You're gonna get.
you're gonna get in faster. Well,
They
that
do
is
think
not the case.
They do think that, and I really wish there
They
needs to be
get
a public
mad.
announcement that says that isn't happening all the time anymore.
Well, and there's I'll just put it out there. There's a few baby medics that are like, but we brought them in. It's like, that doesn't buy them a
That's how
room.
that works, yeah.
You're busy because you're busy.
On the flip side, patients who should call the ambulance.
Yeah.
And come by
Yeah.
EMS decide not to,
Are the
like a lot of
ones
our
that in the
strokes,
waiting room,
right, or a
yeah.
lot of our strokes who
Yeah.
we're staying in the waiting room will present with kind of vague complaints, so.
Right.
I got two things.
All right, Jeremy, you done?
Yep, that was all I had.
All right, thanks.
Firstly, recently I've been getting some calls for termination of resuscitation, which is great. I love getting those calls. I love utilizing our resources appropriately, especially for people who are down for a while. The presentations have been a bit challenging. So when people call, right, you gotta start with a good, complete history. This is I get, hey, Dr. Mohammed, I want to call for termination of resuscitation. We've done CPR for 20 minutes, blah. I have no idea how old this person is. I have no idea how long the person's been down for. I have no idea what you've given. I have no idea what comorbidities they have. And now I have to go through a whole string of questions before I have an idea whether I should appropriately terminate this resuscitation or not. So I behoove everyone to please give a presentation, and it has to be age. If we know the comorbidities, when they were last seen, was it unwitnessed or witnessed CPR or witnessed arrest? How long we've done CPR for total? What was the initial rhythm? What's the rhythm been so far? Do we have are they intubated or they have an I-gel? What's the capnography? What we've given? If we've done any shocks? And lastly, have we talked to the family? It is exceptionally frustrating when I have to ask in the middle of the night, like 2 or 3 in the morning sometimes, and ask like, well, what have we done so far? Have you talked to the family? Because if you don't set the stage for the family, and then you turn to them and be like, and they're dead, like, it sucks for the family and it sucks for us. And the family walks away with, they just gave up and we did nothing, right? Despite seeing what we've done both in the field or in here. So we have to have those conversations and we have to present appropriately, right? So I would behoove everyone, just either take a second before calling me and be like, okay, let me put my thoughts together. It's even if we don't know the age, 50-year-old person, 20 years old person, give or take something that puts us in a realm of where they are. This is how we found them. This is what
I mean, hey, Dr. Mohammed, I got a 56-year-old male found down. We've been doing 20 minutes of ACLS protocols. He's got an I-gel in, he's asystole. I'd like to call him.
Right.
And that's a picture probably as well as you're gonna get. I mean,
If I can get
especially 2 o'clock in the morning.
comorbidities, right, if I can get comorbidities, if you're going to a nursing home, you're gonna have papers there,
Sure.
right? Read the papers real quick first, see what they've given or done. Give me an idea what you've given.
They've done nothing.
Yeah.
What they said was 5 minutes ago, they were fine.
Yeah.
You're doing this on
First
this table.
day, right?
Yeah.
First day and they're fine 5 minutes ago.
Exactly.
So
2 liters per hour breathe.
right.
Don't forget that.
So a good history would be really helpful. From a med mal perspective, it's also really important to understand, is it an I-gel or are they intubated? Is there end tidal or is there not? That helps us kind of give a better sense, because if you look at some of the data out there, an end tidal greater than 20 is hard to call it on, right? If you're perfusing it enough that your end tidal is going above 20 or so, definitively above 30, you may have PEA in front of you, but in reality, you actually have a rhythm that's just not perfusing well enough that the person is creating a palpable pulse. So it looks like PEA in the monitor, but in reality, it's really slow bradycardia that is just not creating a perfusable, palpable pulse. So that's the first thing. The other thing is recently we've been having some what have been called as stroke alerts from the field. And when they get here and I ask them, well, what are deficits or what are, what's your concern from a stroke perspective? They tell me that they're altered. And I have, outside of an intracranial hemorrhage, right? An intracranial hemorrhage is appropriate to say, hey, I'm concerned that they're altered because they're bleeding. That's one thing. But when we're calling a stroke alert for just altered mental status, and based on your exam, you have no focal neurological deficits. There's no aphasia, there's no dysarthria, there's no sided weakness. There's no even sensory deficits. And it's just that they're altered. I can't really in good conscience call that a stroke alert. So I'm okay with erring on the side of caution, but give me a reason why we're calling a stroke alert besides just altered mental status. Altered mental status in and of itself, it just really doesn't buy you a stroke alert, but it does create all these resource intensive processes that may not get us where we want. And then let's just do a better exam. That's what I'm asking for. All right, so we can take it back to the team. If we're gonna call that, bring it with something that shows me that you've done a proper evaluation that says, hey, I have a reason why I'm calling this a stroke alert. They've got gaze deviation, they've got some deficit, they've got slurred speech, they got some, they even, or they had something and now it's resolved. That's also
Positive on the scale,
something, right? Because if we're calling it that from the field, or acute onset dizziness, you're thinking it's the cerebellar stroke, great too. But just altered it, and I've had that in like here and there, I was like, okay, it's not a big deal, but it seems to be more of a consistent nature. And so I think doing a little bit of a better history and physical exam and presenting with that helps a lot more help. And obviously capturing the last well known. I get a lot of like, hey, this person maybe is a stroke alert, and then go, when's the last well known? I go, I don't know. Well, that plays a huge role.
That's key to
in what I can do for this patient or what I can't. You know, those are my two.
Anybody got any comments, questions, concerns?
I just want to kind of tag onto that from the trauma perspective. It's not a huge problem, but we are seeing it. So trauma activations are 99% of it's based on mechanism of injury, not what the patient looks like, what happened to the patient. And so it's really easy in the 30 seconds that these people are trying to give us an IHERN. And I know you think we don't listen to them, but we really do, because it makes the decisions for us. So it happened where the medic made a statement and the nurse interpreted it very differently. So what the medic said was everything is intact. And what the medic meant was the steering wheel wasn't cracked and the windshield wasn't cracked. And so the nurse interpreted that as no damage. So that's not a trauma activation. And then we saw pictures of the cars. Oh God, it was awful. Like there was intrusion, airbags went off. There was, I mean, it was mangled. So just, they have to paint that clear picture. And I know it seriously, they're like coming down 8th
But steering
Avenue
wheel was
and
good.
steering wheel was intact.
Steering wheel was intact, okay.
Patient wasn't intact, but steering wheel was intact. So it's just painting that picture because we aren't there. And I will tell you, I don't know why people use Everbridge. Everybody uses Everbridge. Nobody else would use it. If we had seen those pictures, we would have had it. Like I would probably had it from a certain in the
On eBridge, I sent some feedback on a recent message that came through. Park County sent in a picture. Sent in a picture as a trauma alert, but no.
It was just the lady.
Yeah, it was just the lady.
To do with
It
that.
was just the lady, right? It was just a nice lady in a picture, just hanging out. And it was a trauma alert. And so when I got it on my phone, I was like,
Why?
great. I love that we're using it. I'm super happy that we're using it. And I'm sorry to call out Park County for this if you're on the line, but no, because it's good feedback, because then they came back and gave me some more information. So I wrote back and I said, can you give me some context? Because just a picture and a trauma alert, unless you show me this is the hand and it's now here, and this is the rest of the wrist, that's a great picture. But if I just get a picture of a person, like you got it off Google search, it is not really like as helpful. It wasn't as helpful. So please, when you use the eBridge, just throw in some context. You know, 50-year-old female fell down in the shower on Eliquis, has deformity to the shoulder. This is what she looks like. That's super helpful, right? And that's they end up writing back. Fell in shower and on Eliquis. So if they can give some information. The picture, I love that. I know. I love
The picture looked great, right?
I love that it's being used, but I just a little bit more.
I questioned a paramedic yesterday, or it was kind of a nasty run, ended up being changed to a level 2E. And I said, hey, did you use eBridge? And instantly it was like this, and she said, this particular medic said, I was busy. I said, I understand. I said, she's got 5 pictures on her phone because I'm looking at them. And I said, she could have uploaded them for you while you were busy doing your stuff. And I said, just you try to use and I don't, it wasn't done intentionally. I think she truly was so focused in on taking care of this patient. But she did call a trauma alert, and what would have been nice for everybody to have gotten that. Does that make sense? I'm not saying the team didn't do wrong. I mean, she just didn't use it, just didn't utilize it. It was a tool that could have been used with.
And it does help us.
And especially the bicycle, the pictures.
Yes, the bicycle one was another one. It was like, oh,
Yeah.
that's not just a car versus bike. I mean, like they obliterated his bicycle.
Yeah.
No.
How about, what if so how many departments are using eBridge right now? Besides,
Fire department, Transcare, Ileana, Park County, but Ileana still hasn't done anything.
okay. What if we put together a little,
I think Honey Creek
contest?
has it actually.
A little contest for the summer, since summer, obviously we have more traumas. put a little contest, whoever uses it more and appropriately, right? You can't just send me in pictures of everything that's worthless than anything, and like, I'm getting it for, you know, Chris Kermsey. But no, but how about we put a little contest? We'll do that, we'll track it. You get a star, and come Labor Day week, or we'll call right after Labor Day, because Labor Day will probably still continue getting some trauma. We'll do that, and then we'll get a good prize, not like some cheesy weasy prize, but I'll put together.
Use it a lot for the STEMIs. I think because the STEMIs make them more nervous.
They do use a lot for STEMI.
We all, inside and outside the hospital, have a tendency to.
This particular paramedic I was
Oh,
talking
they
to,
just-
they said, I use it always for every STEMI.
Yeah,
I call
like
in."
I see some beautiful
Yeah.
STEMI strips. I'm like, oh, even I can tell that's a STEMI, you know. I think because those are the patients that make them nervous.
Write that down. Jen.
Okay.
That's all I've got. Anybody else have anything they'd like to bring up as new business? Lori, Matthew, you guys back here? Kev, new business?
No.
Brian?
Nothing.
Good. We'll put that out.
Later, yeah.
Anybody online have anything else for new business?
Nope.
All righty, we're gonna adjourn this meeting now. I'm gonna go on mute, and we'll be back at it at 9 a.m. Good morning. I was on mute. Sorry about that. So, we're gonna go backwards here for a second. If you're in the room, you do not need to do the quiz in order to get credit for honor review. You're here, make sure you're signed in. If you're online, email me, let me know that you were here. Also, there's a quiz at the end, has put your name, your service, and the email address, and there's a couple, 3 or 4 silly questions on there for you to answer that show that you watched it and paid attention to the quiz. So Brenda is not here today to do her report, so I'm gonna go ahead and read it for her. So 3:31 in the morning, dispatch via 911, 80-year-old male with chest pain arrived at residence at 3:40 to find a male sitting in a chair. He is pale and diaphoretic, complained of back pain that began radiating to his chest, down his left arm. Described as sharp stabbing, also reported being nauseated prior to EMS arrival. Due to the confines of a house and unable to get the cot to the patient, assist the patient with ambulating to the cot at the front door and secured and moved to the ambulance. At 3:45, 12 lead EKG obtained showing sinus rhythm with ST elevations in 1 AVL V2 with reciprocal depression in lead 3. At 3:50, they gave 324 of aspirin, 353 20 gauge IV left hand, 500 saline TKO. 355 vital signs are 164 over 112, heart rate of 82, respirations 18, a pain a 10 out of 10. Unable to get an SpO2. Okay. 357 STEMI alert called to Union with pictures sent via text. 58 morphine 5 milligrams administered. At 4 o'clock, nitro 0.4 milligrams sublingual administered. Wow. 406 vital signs 132 over 72, heart rate 82, respirations are down to 16, pain is 0. Write up states the pain is unbearable. States the pain 0 out of 10, but writes that the pain is unbearable. Interesting. Morphine 5 milligrams again at 0.4 milligrams sublingual nitro administered. Patient still complained of unbearable pain at 9 out of 10. I'm gonna bet that's supposed to be 9 out of 10 at the top there. So throw it out. 416 fentanyl at 50 mics. Push. Vital signs staying relatively good for all that juice. 28 over 70, 74, 16 pain is only down to an 8. Nitro 0.4 submit again at 420. 430 arrived to Union, transferred to trauma 3. 435, although patient reported no medical history to EMS, Union unable to confirm the patient history of hypertension, hyperlipidemia, renal lesion, depression, VP shunt placement. Cath 25 years ago in Bloomington, doesn't see a physician and doesn't take any meds daily. At 4:57, arrived at the cath lab. 5:19, the balloon catheter advanced target vessel and inflated. Successful PCI of the left anterior descending coronary artery with reduction of stenosis from 99% to 0, reduction of LAD, diagonal stenosis from 100 to 0. Patient has severe 3-vessel coronary artery disease and will require further workup. Right femoral artery angiosealed and patient transferred to ICU. Door to balloon time was 49 minutes. That's pretty good. It's a good time. If I got any thoughts on that?
Who around here still carries morphine?
So it come from Marshall? Do they use it over there?
It could be in their protocol now, then since they don't use our protocols anymore. So no one in our service should have it, and we only have it as a backup, and you shouldn't be using it first. So to give morphine twice, give morphine before nitro. Any thoughts, anybody? This is a discussion, is a way to learn something. I just want to, you got Matt, you got anything? Okay.
No, nothing.
All right. So overall, March, we're at 100%, so we're 85% for the year, which I'm sure will continue to get better. I had a fallout in February. So no questions at all for me on this one. Gonna move on. Yeah, we're gonna move on, I guess. I hate that. Thank you. Beth is going to do our stroke report. Beth Harrison is our stroke program coordinator. Thank you.
Thank you.
If I were you, I would just use the arrows.
Exactly. Good morning, everybody. Oops, I hit the wrong button already.
Yeah, the other arrow. There you go.
This is a run that was here in the county. It was a 66-year-old male, had no significant cardiac or neurological history. His only prior medical history were hypertension, COPD. He was diabetic. He had some sort of unknown liver disease and high cholesterol. He lived independently with his wife and was independent with all of his ADLs. And for this one, EMS was called at 1308 for patient with complaints of right-sided weakness and loss of speech. Dispatch on 9:57 and route at 10, on scene at 10:19, and I arrived the patient at 10:20. On arrival, EMS found the patient sitting in a chair. His wife reported that she found him slumped over a chair at 09:45 that morning. And the patient was very short of breath, only had an O2 sat of 80% on room air. It was not moving much air. His O2 was, he had 2 liters ordered at home. Of course, he was non-compliant with it. So he was very short of breath when they got there. EMS did do an assessment on him. Time they got there, his weakness had progressed. He's totally flaccid on his right side with aphasia. His aphasia was different. It was completely incomprehensible speech. Blood pressure is a little bit high at 171/120. They did apply his O2, gave him a couple nebulizer treatments, and his SATs went up to 98%. They did do a Cincinnati pre-hospital stroke scale, no Van scale. It was grossly positive. And I will say that the charting on this case was very good. There was a very thorough history documented, looked at everything that could possibly going on that might prevent us giving a thrombolytic when he got here. He has on no anticoagulants, no trauma. The EMS did a great job working with his wife to get a lot of information that we needed when he got here. A stroke alert was called to Union at 10:57 with an ETA of 5, and they left the scene at 10:41 and arrived at the Union ER at 10:59. When he got to the ER, his stroke symptoms had progressed. He had an NIH of 17 on arrival, which is a moderately severe NIH score. For mild to moderately severe runs from like an NIH of 15 to an NIH of 24. On the higher end of that scale, usually never see anyone with a 24, greater than 24 severe, but usually never see anyone with get that high have survive. So his NIH was really climbing. He was having a pretty severe stroke. And he had incomprehensible speech, but he had receptive aphasia. And I'll get to that in a minute. CT of the head stroke was done at non-contrast at 11:11. Teleneuro was consult 11:14, and he received tenecteplase at 11:26, which is a door to needle time of 24 minutes, which was awesome. Really great time. And they did do some advanced imaging. They did a CTA of the head and neck, and they did a CT perfusion with contrast, was complete at 12:06. They used our rapid software, which did show the hypoperfusion in the left cerebral hemisphere, posterior laterally. They said it was likely involving the left parietal and the left temporal lobe. There was no core infarct and no LVO, so there was no clot that he could go in and move. He was just having a pretty significant stroke at his temporal lobe. They did transfer him to ICU for further monitoring. And when he got to ICU, his NIH was 6. So after the tenecteplase, he had great recovery, went down to a 6. The MRI of the brain was completed at 21:28 that evening and showed a left temporal stroke. And what was really interesting about this patient, this is something I rarely see with our stroke patients. His stroke ended up being in the posterior temporal lobe, which is where your language centers are located in your brain. And he did have some very significant receptive aphasia or vertical aphasia. It's in the Brodmann area of the brain, and it's usually it's the posterior temporal lobe are the dominant hemisphere. So that's most people, they're left brain dominant. That's why his stroke symptoms were on his right side, and that's where his language centers were located. And even from the EMS, his speech was noted as incomprehensible. And this type of aphasia, they speak very fluently. It could be up here just carrying on a conversation, but it's nonsensical, and they have no language comprehension. You know, usually you think aphasia with a stroke patient, they're very frustrated because they can't get the words out, and they have that slurred speech. and they have a hard time and they're trying to tell you something. They understand when they're trying to tell you sometimes their point. With this type of aphasia, he was carrying on a conversation with me that was totally nonsensical. You know, it was like words, making up words that didn't exist. He was very happy because it totally took out his language comprehension. It's pretty rare to see this. It's really interesting to see, but really sad for him, but he didn't know that he wasn't making sense, and he didn't know that you weren't making sense to him. So he was living in his own world. For his disposition, time he discharged, his MAH was down to 3, and it was all pretty much due to speech. He was able to ambulate over 200 feet. And we did discharge him home with his wife. He was able to be independent with most activities of daily living. And he was getting outpatient physical and speech therapy. So I'm going to say EMS did a really good job on this, a lot of good documentation. They called the stroke alert. We were able to go directly to CT. We have a lot of history that he wasn't on coagulants. We kind of look at those things. And those great steps really do reflect in that door to needle time of 24 minutes. You know, it was a great job. So from our EMS and our ER team. So thank you.
Thanks, Beth. I appreciate it. Thanks, Chris. Will Losey's up. He's going to do the Union Hospital Clinton couple case studies.
2 runs from up north. First one is a 54-year-old male, history of hearing loss, bradycardia, smoker, sleep apnea, COPD, syncope, a implanted pacemaker, and sinus syndrome. Family called 911 for decreased level of consciousness and slurred speech. EMS arrived at 22:53, or notified at 22:53, sorry, arrived at 23:10, departed the scene at 23:25, and arrived at UHC at 23:42. From the run report, they were dispatched for a male who was not responding, had slurred speech. On arrival, the patient was found sitting on a chair in the front porch with first responders from the fire department. Patient's head was limp, had him on a non-rebreather, 15 liters. They'd been doing a lot of work outside that day, thought they may have overdone it. I had previous episodes similar to this at home. Was responding to some loud voices, would open his eyes at times, but was not acting appropriately. Patient was warm to the touch, brought the cot close, asked if he could stand, was unable to get up to himself, so they assisted him. Placed on a monitor, vital signs taken, 12 lead done, showed a pace rhythm at 60. Non-rebreather was removed to check SpO2 and sat between 95 to 97. So asked to open eyes, squeeze hands for the crew. Did not document a response to those, however. IV was placed 20 gauge and 500 liters nasal saline was hung, 150 given in transport. Patient did try to get up off the cot a couple times, asked questions inappropriately, with mumble answers in response to questions that were given to him. Arrived to us at 23:45, taken to CT at 23:48. Neuro assessment was completed at 00:15. No T&K was advised. Last known well was 7 o'clock, and he was having some improvement in his symptoms. Torbis for swallow valve was completed. Plans were made to transfer to Terre Haute, both for MRI and neuro follow-up. Had difficulty getting a bed assigned. Unfortunately, the patient decided to leave AMA the next day while he was still waiting for his bed. This particular chart didn't have VANS or Cincinnati stroke scale charted in the run report. And both the ER report and the EMS noted difficulty in assessing and getting any kind of history out of the patient due to his impulsive nature. Our second case is a 70-year-old male, history of CAD, called 911 with chest pain and near syncope. EMS was notified at 5:26, arrived on scene at 5:34, departed at 56 after, and arrived at Union Hospital Terre Haute at 6:21. We had a 70-year-old sitting in a recliner at home, was awakened by his chest pain, was given nitro by a spouse, became diaphoretic and had a syncopal event, GCS of 15 on arrival of EMS. Pink, warm, dry, pupils are reactive, breath sounds clear, they'll be delirium. This is the first time the patient had ever taken nitro. And 1 week prior to this, had no cardiac history. It was gone to Union Clinton for the a heart scan that they offer, and was referred to cardiology from that visit. They did do a heart cath on him, which revealed need for eventual bypass surgery, which he was being scheduled for. 12 lead on scene to identify an inferior STEMI. They did a good job evaluating the home meds, looking for any other indicators that they would not be able to do nitro. Vitals are monitored throughout, 4 liters nasal cannula. IV 18 gauge was established, lab strong, finger stick 132. Patient was given 324 of aspirin. E-bridge was utilized to activate for STEMI. Patient tolerated well. They did withhold nitro due to low blood pressure. Again, the inferior STEMI. Patient arrived at 6:25. EKG also confirmed STEMI. Was taken to cath lab, had 100% inclusion of the RCA. Balloon stented with 0% residual. Admitted to the ICU, discharged home. Reperfusion of 76 and first medical contact reperfusion of 126. So utilization of E-bridge, good job looking at home medications. Deploying nitro. This last slide is kind of informational for you guys. The chest pain teams, both in Terre Haute and Clinton, made it a goal this year to provide 100% feedback on STEMI runs to outlying facilities and EMS that laid hands on those patients. So this is the form that we kind of came up with. Looking at the times here, first medical contact, reperfusion, are they activating in the field to give that pre-notification? Because as Beth said, that is super important, kind of regardless of what we're dealing with. Kate from the cath lab has given us images so you guys can actually see the return of flow that is provided with this. And just a brief little summary at the top with any highlights, opportunities that we identify in the runs. I know as working in the ER, you send those patients off, you always want to know what the heck happened to them. So this is just something for you guys. If you guys do identify something that you would like to see, please let myself or Barry know. This is a living document. We can update it to whatever makes it functional. Want to make it good for you guys, make it good for the hospital.
Thanks, Will. I know I send these out to the services and then hopefully they get those out to everybody that needs to see them. So we are going to skip ahead to our last presentation first. Next. Robin is going to talk about OB assessment and difficult OB cases and things in the field. So I appreciate it. Robin, this is EMS. Good luck. Yeah,
Hi, I'm Robin.
Use the arrows.
Okay.
Perfect, thanks.
I'm a labor and delivery nurse. I've been a labor and delivery nurse for 15 years now here at Union Hospital. This is a presentation I made for the ER staff upon request, just so they would know how to take care of OB patients that present to the ER, because sometimes they either don't know they're pregnant or they present with other complaints. So the objectives are, you know what important questions to ask a pregnant patient. You'll know how to properly assess the pregnant patient, and you'll recognize signs and symptoms of life-threatening pregnancy complications. So there's lots of differences in all the medical people. My sister's an ICU nurse, and we joke that I want nothing to do with the heart stuff, and she wants nothing to do with uteruses. So, and that's fine. That's why it's great. And my goal is to not make you feel like you're stupid and don't know anything, because if I had a patient having a heart attack, I'd probably shove them in your door and walk away. But if you have a patient that says I'm either pregnant or have a snake in my vagina, I'm thinking, I hope it's a baby. And you guys are probably thinking, well, I hope it's a snake, because you don't want to deal with the baby. So if you have a patient that's presenting to you guys, you need to ask them what they may be seen for, what their gestation is or their due date. If they're after 28 weeks, you want to make sure they're having regular fetal movement. Ideally, we want 10 movements in 2 hours. What pregnancy is this for you? And how many times you've given birth, if it's vaginal birth versus C-section, just because the risk factors associated with like repeat cesarean sections. Other questions to ask: who your doctor is, if they have a doctor,
Any problems with their pregnancy, any chronic health problems, any vaginal bleeding or leaking fluid. So if it's bleeding, have the patient describe a mountain collar. I always say if they're bleeding a lot, is it like larger than, does it fill up a pad an hour? Because, you know, patient's definition of a lot and our definition of a lot are two completely different things. And if they used any drugs, illegal or others. Of course, you do vital signs on every patient, oscillate heart and tongue and lungs. Pain, if they're having pain, if they say they're having contractions, when they say they're having a contraction, if you put your hands on their belly, you want to feel their uterus. When they're having contractions, that uterus will get firm. The firmer the uterus gets, the stronger the contraction is. And you want to make sure after the contraction's over, that uterus relaxes in between. If they have any UTI symptoms, pregnant women are more prone to UTIs than normal women are. And those UTI symptoms can cause, or UTIs can cause contractions and other issues too. So we always ask that. Bleeding, color and amount, the same, like I said before, especially if it's bright red versus dark red to old blood. Leaking fluid, if they have any headache, vision changes, reflexes, clonus, or edema, those are all preeclamptic signs. Like I said, fetal movement. And then do you guys keep Dopplers in the ambulances? No, okay. If you do have a Doppler, you want to try to assess heart tones. Listen for 6 seconds and multiply it by 10 if you can. If they have delivered already, but you want to ask about the headache, vision changes, epigastric pain, edema, same for preeclamptic assessment. You can get preeclampsia like 6 weeks, up to 6 weeks after delivery. So that's still important to assess. When assess if they're complaining of flu-like symptoms, sometimes they'll have mastitis. So ask them if they're breasts, if you don't want to look at them, you want to protect some of their decency. But usually after they have a baby, they've lost all sense of modesty. But you want to make sure their breasts are soft, they don't have any red areas or streaks, just because that's mastitis can make people really sick really fast. You want to make sure their fundus is nice and firm. It should be below the umbilicus. Usually if it's above the umbilicus and it's not firm, they're bleeding too much. They have a bleeding issue. The lochia, which is the bloody discharge that women have after they deliver. See what color it is, if it's a large amount, if it's a small amount, if they're passing clots. And once again, I ask patients, are you soaking more than a pad an hour? Are you passing clots? And sometimes they're passing clots, but their clots are like the size of a dime. I don't care about those. Baseball size or larger, those are the ones that are concerning. And if they're soaking more than a pad an hour, that's usually when it's concerning too. If they say if they like delivered at home and are bleeding excessively, sometimes you can see those gaping lacerations in their perineum. So you want to kind of assess that and see if they have a huge hematoma or anything and apply pressure if needed. So this is life-threatening OB emergencies they might present to you guys. A cord prolapse. So cord prolapse is when the umbilical cord slips ahead of the presenting parts and protrudes into the vaginal canal. So either sometimes you cannot see this visually, you can just see it when you do a vaginal exam, the nurse or the doctor, or I've had it where before you can see the cord protruding out of the vagina. So if that happens, you want to put on preferably sterile gloves, but really any gloves will do. And you want to manually elevate the presenting part. So you do not want to push the cord back behind the baby's head because you can occlude it and not know you're occluding it. So like if the cord, like here's the baby's head and the cord's coming below the head, you want to push the head up off the cord so you're not occluding that blood flow to the baby. You can reposition the patient in Trendelenburg to get less pressure off that cord if that's a better position, depending on where the cord is prolapsing through. Start IV bolus oxygen, get them to the hospital as soon as possible, alert the hospital that they're coming and that they need a stat C-section. Here at Union, we are lucky because we have an OB hospitalist in-house 24/7, and we have anesthesia dedicated to our department. So we can get that OR ready and be ready to go as soon as you roll through the doors. And if you do have a cord prolapse and it's protruding through the vagina, if you can palpate, so you're holding the head up with one hand and you're palpating the cord with the other hand, that way you can keep track of how fast that heartbeat is. And sometimes, no matter how well you're holding pressure off, it's still nothing you can do. You just do what you can. A shoulder dystocia is when there's a size discrepancy between the fetal shoulders and the maternal pelvic inlet. So what happens is the head delivers and that shoulders become lodged behind the pubic bone. Usually on your precipitous deliveries that most of the time you guys have, it's not an issue. Usually if they deliver fast, the shoulders aren't gonna get stuck. If that does happen, though, you can do McRoberts maneuver, which is you lay the patient's head completely flat, you extend those hips out, so they're kind of like this, and you pull them back. Suprapubic pressure, you make a fist and you put it right above the pubic bone and you push on that shoulder to try to dislodge it behind that head, behind that pubic bone. Or you can deliver the posterior arm, which is a maneuver that the doctor does. Complications for the mom includes a hemorrhage, a bad tear, or possible uterine rupture. For the baby becomes hypoxic because it's not receiving oxygen or blood flow. You can fracture the clavicle, you can break the humerus, or you can damage the nerves by a brachial plexus injury, but those are all better than a dead baby. Or it can cause death also. Placental abruption. So placental abruption is when the placenta separates before the baby is delivered. So it's a premature separation of the normally implanted placenta from the uterus after 20 weeks of gestation. So different causes of that is severe maternal hypertension, drug use, especially cocaine, methamphetamine. If they are multigravida, meaning they've had several deliveries, usually greater than 6, cigarette smoking, if they've been in a car accident or fell and hit their belly somehow, and sometimes people just abrupt with no reason. So how she will present to you is they'll have bright red vaginal bleeding, they'll have excruciating abdominal pain, and that abdomen palpates firm. How I talked about filling that belly and making sure that uterus relaxes. It doesn't relax. It's always hard, and usually it feels like as hard as this desk is. And if you do Doppler heart tones, usually they're not reassuring, or they're saying they don't feel the baby move. So abruption, sometimes you will have all those symptoms, and then sometimes you'll just have 1 or 2. You just have to use like all the clinical presentations together. So you start an IV, do fluid bolus, give oxygen if mom needs it, because sometimes they get upset and need it for their support. And then you, same thing, notify the doctor, notify the hospital that you're going to so they can get ready. Preeclampsia. So preeclampsia is a complication characterized by high blood pressure and signs of other damage to other organ systems. Most of the time it's the liver and the kidneys. So with that, you have an increased blood pressure, you have a headache with no relief with Tylenol or rest. You have blurry vision, seeing spots, brisk reflexes, clonus, and epigastric pain just from the liver being inflamed. Sorry. So once they get to the hospital, we'll do labs. We treat blood pressures 160 over 110 with appropriate medicines. That's considered a hypertensive emergency if we have patients' blood pressures that are higher than 160 over 110. And the thing with preeclampsia is where we are worried about them either having a seizure or having a stroke or possible brain bleed from all the high blood pressures. Pregnant women are more susceptible to that just because of all the changes their bodies go through during pregnancy. They're more susceptible to those brain bleeds. That's our labetalol algorithm and our hypertension emergency checklist that we've installed. So we now can automatically give those medications. It's in our standard plans of care. Postpartum hemorrhage. So after you deliver, you could bleed too much. And this doesn't have to happen right after delivery. I hemorrhaged 6 weeks after I had my child at home. So it can happen anytime. So you're considered hemorrhaging if you have a blood loss greater than 1,000 cc's. Causes are uterinectomy, meaning that uterus just does not want to contract and firm up. Retained products, even the tiniest piece of retained placenta can cause you to hemorrhage. Or if you have a laceration that does not need repair, which hopefully if they're postpartum and you're getting them, hopefully that's not the case unless they had a home birth that's not attended. So for you guys, use IV fluid bolus. You guys probably don't have uterotonic drugs on your ambulances, so call the hospital, let them know you're coming so we can be ready. Communication is kind of the biggest thing, which I feel like you guys notify the ER and the ER does a pretty good job of notifying us too. So that way it could be less of a delay of care for these patients. That's our hemorrhage score. So certain things put you at a higher risk for hemorrhaging, such as greater than 4 vaginal deliveries is the big thing. Or if they've had previous C-sections, that's usually puts you at a high risk too. Postpartum hemorrhage is one of the leading causes of death in our patient population. So it's important to be more vigilant about that. So I kind of didn't go over delivery because this is for ER nurses here. And we're right down the hall, so usually we run up to do those deliveries. But if you guys have a delivery after the baby delivers, the most important thing you can do for this baby is dry and stimulate. If a baby gets cold, it can lead to respiratory depression, respiratory distress, hypoglycemia. And once that baby gets cold, it's very hard for us to get it to warm up again. So dry, stimulate. If the baby's stable, if mom's stable, the best place to put skin to skin and keep them covered with warm blankets. You can cut and clamp the cord. And then just call and let us know you're on your way so we can be ready for you. If you do have it's considered a spontaneous abortion, less than 20 weeks delivery. I know no one wants to do that delivery. That's not one of the deliveries I enjoy. But you have to remember, to the patient, that's still a baby, even though to us, it's a spontaneous abortion. The minute a woman finds out she's pregnant, it's a baby in her mind. So just, same thing, cut and clamp the cord. Try to wrap the baby up, see if the ball wants to hold the baby. Just try to give her a little respect, I guess, or empathy. Maybe that's a better word, because to her, it's a baby still. Do you have any questions?
I have one. So if they're further out in the county on their way here, deliver, everything's good, but skin to skin, can the mother start breastfeeding then? Or
Yeah, if the baby looks
if
okay.
They want to.
Yep.
Okay.
So you want to listen to the baby's heart and lungs, making sure their respirations are less than 70. Baby's lungs are not clear. They'll kind of sound junky, but you'll still be able to hear breath sounds. But it's normal for them to kind of be junky, especially if they deliver quickly, which is most of the time what happens with you guys. But yeah, mom can breastfeed, and that will help her uterus contract too, because it releases Pitocin. If the placenta delivers for you guys, keep the placenta because we'll take it. And send it to pathology or lab. Anything else?
Any other questions?
Know the time the baby delivers, if it's helpful.
Couple things to remember. If you're the one holding a part, you're dedicated to that, right? So you're not moving, you're stuck. So
Oh, for the
you
cord?
gotta- Right.
You are riding that bed to the OR.
If you are a 30-minute ride, you better get comfortable, please.
Yeah.
Right, in one way or another, that's the first thing. And then just remember, infants or neonates at the very early stages of life will be hypoxic to us, but their hypoxia is actually fairly normal. First couple of minutes, they may be in the 70s to 80s, and you'll freak out. It's actually fairly normal. It should improve as it goes through.
At 10 months of age, the baby's saturations will be 85% is considered normal. So it's 10 minutes,
So
85%.
don't get scared. But get scared.
Don't get scared.
The biggest thing I think is communication to the ER that you're going to, so they can be prepared, so we can be prepared. Because, yep, dry, stimulate, switch out those blankets if needed, try to keep that baby warm.
Questions? Thank you very much.
You're welcome.
Really appreciate it.
No problem, thank you.
Thank you. I love it. I love it. It's fun.
5.5 hours after water broke on the fourth kid. So do something about it. Yeah.
Miss Tina, you're up. Had to get out of order there a little bit. Robin had to get back down. She's got some patients or somebody delivering babies. So Tina Hedges is going to do the trauma report.
Morning. We got 2 cases today. So the first one was a 45-year-old male with a blunt trauma, the work related and the site. The 911 call came at 6:26, dispatch 6:27, and route at 6:27, on the scene 6:32. Departed the scene at 6:50, at Union ER at 7 o'clock. Times called dispatch minute, dispatched in route was 0 and route to arrivals 5 minutes. They were on the scene 18 minutes. Departure to arrival was 10 minutes, so total time was 34 minutes. Pre-arrival note, the patient was trapped between 2 pieces of equipment. It was a level 1 trauma alert. They called right hip, femur, and left ankle injuries. They arrived in the ER at 7:07. Trauma surgeon arrived at 7:14. They complained of right hip pain. He had limited range of motion. To his hips bilaterally, the right hip was shortened, internally rotated. Pelvic binder was intact. He had pulses bilaterally. Abrasions to the left lower extremity. Vitals were stable. His fast was negative. I missed part. Go back just a second. There we go. EMS dispatched for an unknown reason. This is very beginning. Sorry, I missed this. Patient states he was crushed between two pieces of machinery. They were two big rolls of aluminum, the thin rolled aluminum. The second machine grabbed his legs from behind and pulled him, twisting him to the floor. He was placed on the backboard by his coworkers prior to arrival of EMS. He was pinned. He was not pinned and didn't require extrication from the machine. They were able to get him loose, I guess, or it threw him out. He was alert and oriented. He had an obvious deformity to his right leg, unstable pelvis, deformity to the right femur, shortening and rotation of the right leg, deformity to the left ankle, the swelling to that area. They did put on the pelvic binder and they called a level 1 alert. There we go. Now we'll go back. Diagnostics, the x-ray of the pelvis showed traumatic separation of the pubic symphysis at 4.4 centimeters. Dislocation of the right hip. Right femoral head was dislocated superiorly. He had visual CT of the chest, right femur, left ankle labs. He was accepted to IU Methodist, but they couldn't fly him because of weather. So they transferred him by ground. Diagnosis was pelvic fracture. It was an open book fracture. The ER and a right hip dislocation. The ER provider said that they didn't reduce the hip because of the dislocation, concern for dislocation and the open book fracture, and they were concerned with causing bleeding in the pelvis. EMS had applied the pelvic binder in the field and the binder was left in place and not removed, which was the correct thing to do. And this is a picture of the fracture. It was a big fracture. I mean, it just poof. Yeah. So and you can see the binder on there. So yeah. Yeah.
One of them Edison light bulbs.
We've seen weirder.
Yeah, that's a dandy fracture. The pelvic fractures, the ring has no inherent stability. It relies on ligaments support. So fractures and ligament disruptions suggest major force of trauma. Typically follow car wrecks, motorcycle crashes, industrial injuries. Pelvic fractures are commonly associated with intraperitoneal and retroperitoneal visceral and vascular changes. They can bleed out really, really quick. And then a lot of times they'll be hypotensive, but you have to make sure that you checked everything else looking for bleeding sites, that it's not just from the pelvis. It could be chest, it could be anywhere. So you need to make sure that you've looked for all sites for bleeding. I put one up here if you've never seen one. I'm sure you all have, but I think EMS a lot of times uses sheets. So, and they do just as well. Yeah, they do just as well. I know the pelvic stabilizers are kind of pricey, but that's what it looks like. It's real important that when you put the pelvic binder on, you document it somewhere or write it on a piece of tape, put it on there. It's really important we know when you put it on and anytime it is taken off. That it shouldn't be removed unless ortho or trauma tells you to take it off because they can bleed out very, very quickly. And patients, once they are applied, are at risk for skin breakdown. So you need to make sure that you're checking the skin. You guys won't have to, but like if they get admitted upstairs, it's typically not left in place for long periods, but it may be a little while, maybe before they can get to surgery, and they can have start having skin breakdown within just a few hours because of all the pressure from the compression. So their skin needs to be documented, and anytime you loosen it or remove it, you need to make sure that you document it. That's about it. Any questions?
Biggest thing to remember this one, right? Ischial spines. find your ischial spine, so those big parts of your hips, that's where they go over, right? So sheet, nice and tight, it's easy. There's no harm if you think otherwise, right? No one's gonna die from putting on a belt pelvic binder. People are gonna die from not putting on a pelvic binder. So if you, when in doubt, put it on.
Anything else? All right, we'll go on to the next one. This one was just, this was sad. I just thought we would present it just because we don't see this kind of electrocution too often, fortunately. But this was a 27-year-old male with electrocution. 911 call at 10:53. They were dispatched 10:57. En route 10:57. They were on the scene at 11:09. Left the scene at 11:20 and at Union ED at 11:29. I called, this should be 37 minutes. Called dispatch was 4, dispatched en route was 0, en route to arrival was 5. On the scene to departure was 18, departure to arrival in ER was 10, so it should be 37 minutes, not 39. EMS report, dispatch for report of a male who had been electrocuted and was in a tree. They were responding with the local fire department. He worked for a tree trimming company and they were trimming trees. En route, fire department advised the patient was now out of the tree and was in cardiac arrest. They said he'd been cutting a tree, was electrocuted when he touched a power line. It took them 6 to 8 minutes to get him out of the tree so they could start CPR. On arrival, CPR was being performed by the fire department with the Lucas device. Defibrillated ×2 prior to EMS arrival, and IGEL in place. There was vomitus present. They did CPR, they sectioned him, so that was 94% with the IGEL. They put an IO in the right tibia, gave him epi. Monitor showed PEA in the 20s. Pupils were dilated and non-reactive. He had a small laceration to his forehead, but the bleeding was controlled. Had 3rd-degree burns to the left shoulder, 3x3 inch right inner thigh, left inner thigh, 1 inch circular area on the top of his right foot. Went through his boot and his jeans and his shirt all had charring on them. DCS was 3, end title was 44. They called level 1 trauma alert. Pre-arrival note from the ER said cardiac arrest, power line execution, or electrocution execution, sorry. Every ×2, level 1 trauma alert. They paged out 11:27. Trauma surgeon got there at 11:44. Arrived in the ER 11:32. Was in cardiac arrest with CPR in progress. We continued the ACLS protocol, mechanical assisted CPR. We gave him calcium, bicarb, and epi. He was intubated at 11:36. Cardiac monitor and ultrasound was used to evaluate cardiac activity, and he remained in PEA. They did do a fast and it was negative. Pupils were fixed and dilated. Time of death was 11:44. IOPO and the coroner were notified and he was a coroner case. The coroner's final result or report said that it was a high voltage electrocution. He had entrance wounds in the left index and middle fingers, exit wounds of the chest, left mid lower abdomen, posterior left upper arm, anterior left forearm, posterior mid right thigh, bilateral anterior thighs, and medial right foot. Clothing, he had electrothermal defects in the right shoe, right socks, pants, boxers, reflector vest, sweatshirt, and t-shirt. Status post-cardiac or cardiopulmonary resuscitation, and there was no suspicious trauma. So other than the burns, I mean, there was no injury except for the little scalp laceration from him being in the tree. Or it was just very, very unfortunate that they all did a really good job doing the best they could to take care of him, and that they had to wait, of course, to get him out of the tree before they could even do anything. And this just talks about safety at the sites, especially with electricity. It puts EMS at very, very high risk during rescues. You have to survey the site, make sure you stay safe. You can't help anybody if you get hurt. Make sure you park a safe distance away, call for extra help if you need it. Power lines can be connected to backup generators. So you need to make sure you have people that know whether that's turned off or not. Don't ever touch patient till it's safe to do so. And then don't try to grab something to push the power lines away from the patient. That's a good way for you guys to get hurt and get burnt. So that's all on that one. Does anybody have anything, any comments, questions?
Matt, were you on that? Did you have-
I was Bossy.
Yeah. it was Dr.
Dr.
Dossi.
Ruiz, Dr. Ruiz said that he had a lot more damage than even he had anticipated.
Thank you, Tina.
You're welcome.
Well, no question was he was intubated and had an IG CO2 of 44. Just curious. I mean, why?
Fair question. I mean, I was just curious.
Just
Sure.
doing
Just
what
had
we
that
could.
conversation.
No, I know, right? That's a good question.
I was surprised to see the autopsy report where his entrance was, I mean, it makes sense now, of course, you know.
Where-
he can be an armchair
Where you
quarterback,
grabbed.
Where he grabbed,
Yeah.
because he had so many holes in him, we didn't know. what was
Multiple.
what.
Yeah.
Like it went through his steel toe boot, I mean, it just like everywhere.
Entered in through the pole saw where he had in his hand.
Is that what it was?
Yeah. Minimum of 10,000 volt line.
And there was a lot of family dynamics. I don't know about the fire risk part, but because the brother worked for he worked for the tree trimming company and the brother worked for the lawn company and they were both on scene.
Well, didn't they say this was his guy's like first day or first week or
Oh,
something?
I don't know. I didn't know that.
Just started.
Yeah.
Yeah. it just started.
Yeah, it was, we thought we had a couple other patients because there's other people on the ground and stuff. And they were just, the level of being distraught was,
So was he in a bucket?
no, he was manually climbing a tree.
Oh, okay.
And then, so his harnesses, the stuff that are.
Tina, thank you again for the trauma. The last presentation is going to be Chris Thomas, and he had actually approached me, which is very rare that he does this. And said, hey, this might be a really good one to present. I said, sounds like a to me. So thanks, Chris. I appreciate it.
It's pretty straightforward, but it had a good outcome for what we rolled up on anyway. So at the time the call was received, this was pretty early in the morning back in April. We were advised that a 4-year-old male had been run over by a vehicle. They did say that he was conscious, but was acting weird and was advising that he couldn't see anything. This actually shot me back immediately at the dispatch to a call I had 16 years ago.
16?
Yeah,
Oh, my God.
for a 4-year-old that was run over. You know who that is.
I do know. who
Yeah,
that
you
is.
remember who that was. So I immediately, that was a fatality, unfortunately. And so I thought back to that. So when they came back on and said he was acting weird and couldn't see, I'll take that over pulseless and epic. Anyway, so we responded with devotion up in West Terre Haute. We were en route at 908 on scene at 916. Not too bad of a response time from where they were at. We get there. The mom is up on the porch of the residence. She's holding the kid on her lap. This is not him. This was the only like Google image I could find to represent what he looked like. He had gotten up. So basically what we were told by the deputies on scene was that there was a Silverado that was pulling a flatbed trailer that had a riding mower on it. The dad had come outside, not knowing that the kid had followed him outside, was just going to move the lawnmower to do whatever he was going to do. Started backing up and felt resistance, and then did what anybody would do and gave it more gas, and went up again, felt more resistance, finally decided to get out and see what the heck was behind his trailer, and found his son laying on the ground underneath the rear wheel. So what we understand is that the wheel went like up onto his chest, came back down, back up, came back down again, and never went like completely over him. He was able to get up. He walked up to the porch. There was no LOC reported. When we got there, very first thing, I mean, just screaming textbook traumatic asphyxiation, just had widespread petechiae to his head. He just kind of had this 1,000-yard stare to him. At this point, he was saying things were blurry, but I guess initially after the incident, he was telling mom and dad he couldn't see anything at all, that everything was black. So initially vital signs, BP was 106/62. He had a heart rate of 168, respirators were 24, SATs were 88 to 90%. That obviously was one of the first things that screamed, alert, was he was hypoxic. He was moving air, but he was diminished bilaterally. Head, ears, eyes, nose, throat, otherwise atraumatic. He did have good chest expansion bilaterally, but again, diminished on both sides. His abdomen was soft flat, but was tender to palpation. And he was complaining of abdominal pain. At one point, he completely doubled himself over into a fetal position, grabbed his abdomen and just screamed out in pain. Pelvis was stable. Really, as far as external trauma goes, he didn't really have a whole lot going on other than some assorted abrasions. The worst one was down on his left knee. There was no signs of obvious skeletal injuries, no dislocations or deformities otherwise could be found. Put him on a non-rebreather, his sats went up to 96%, maxed out on a non-rebreather. So still you would expect those sats to be higher, maxed out on a non-rebreather. So obviously there's some kind of lung damage that we're anticipating. So the fire department had already requested Lifeline even before we made scene that they get sent based on the mechanism of injury even before they made scene. His LOC started to depress rapidly, and he really started to have an increased work of breathing, was really working to breathe. It was taking a lot of stimulation to get him to open his eyes and respond to us. So at that point, we went ahead and I didn't want to fall behind the 8 ball, so we went ahead and intubated him at that point, gave him some fluids, just continued pain meds and sedation while we transported him to Union. Fire had told Lifeline to just meet us at the ground pad at Union, so we were going there instead of meeting them on scene. In transit for us, he remained stable. Otherwise, we got sats up to like 98%, bagging him. Met up with Lifeline 3 at 9:49. Quick handoff to them. It didn't take very long at all to get him into their aircraft, and off they went. Talked to the flight crew afterwards. He remained hemodynamically stable in transit. They did have to keep their FiO2 on their vent at 100%. If they dropped it in below that, his sats would just, he would just desat. He didn't show any signs of any kind of tension or anything like that while they were transporting him though. Once they got him to Riley, he had bilateral pneumos, chest tubes were placed. He had multiple bilateral pulmonary contusions. He had a cerebral contusion, he had a renal lac and a liver lac. He had no fractures, but again, he's kind of younger, you know, bones are a little bit more pliable. So he kind of lucked out as far as that goes. They kept him intubated for up until the 3rd day. They extubated him and removed the chest tubes on day 3. Luckily, his liver and renal lacs were low grade, so they did not require surgery. They just monitored him in the PICU for a couple of days. He was able to be discharged home on day 5. Unfortunately, the father popped positive for marijuana, which he did tell the deputies that he had smoked the day before, but you know how it lingers in your system. So he did pop positive, so he got charges, operating a vehicle under the influence, resulting in serious bodily injury. I actually tried to get imaging from Riley to include in this, but since it's an active CPS case, they couldn't release anything from his chart to me. And that's as of 2 weeks ago. It's still, and this was back in April, so it's still an open CPS case 6 weeks later. But luckily, he ended up being okay. You know, so looked a little worrisome at first when we started with him, but and obviously had a lot of injuries and potential for more, but in the end, he ended up being okay. So
That CPS case will stay open until the dad's case. So it's-
which who knows how long that'll be.
Exactly.
Thanks, Chris. Anybody have any questions for Chris? All right, I got a couple things I want to talk about before we head out. Dr. Malam, would you like to talk about urology?
Sure.
Coverage
So,
really quick.
yeah, so Barry sent out a message for me about a week or 2 ago. So unfortunately, because of just some extenuating circumstances, our urologic coverage at Union is challenged right now. And so in the instances, if we're presented with a patient that has some sort of urologic, well, let me make that more specific, that has some sort of testicular complaint, right? So testicular trauma, testicular pain, scrotal pain, any of those types of things. In those instances, we will not have urologic coverage for them, which means that we'll have to either transfer to regional or farther up down the road. So this is not to say we won't see them, right? We will 100% see them. But if you're presented with a call for either testicular pain, scrotal pain, some sort of testicular or scrotal trauma, the ideal place to go would be regional. Only because they have Dave and Shanks readily available. They don't have to transfer again from that perspective. And it's the same thing at Clinton, right? If you take somebody to Clinton for that, they'll then have to transfer to regional as well, probably as well. So if there's opportunities to go down the road to regional, that may be slightly better, just because similar to how time is of essence for stroke and time is of essence for STEMI, time is of essence for testicle, right? So I made this joke earlier, we have those of you guys who have two testicles want to keep both testicles, right? So if you want to try and make sure that person has both testicles when they leave, if it truly is an emergency, we want to get them to definitive care. So it's not to say we can't do them again, but it's just that I want to get them to definitive care. So we can get them to there, that'd be phenomenal.
Thank you. I just want to make that clear. Couple other things to remind everybody online and everybody here, RSI testing this month. We're gonna start here in a month or so, July-ish, August. Try to get every paramedic in the system has to go through the RSI testing process unless you have successfully met the needs that we've set the criteria prior to. If you have, I think it's 8 RSIs in 2 years, you do not have to retest. There will be a new test this time and new scenarios, changing that up a little bit. We will have 6, 7, 8 dates coming up. I will get those out to everybody as soon as I know those dates. Dr. Malamed and maybe Dr. Worley isn't get involved and get those dates out for everyone to know. We have EMS skills days coming up September, Tuesday after Labor Day. So it's Tuesday, Wednesday, Thursday, Friday, 9 to noon, Rick Simulation Center. Come anytime you want to come within 30 minutes, you can get all your skills done for 2 years in a 30-minute period of time of 3 or 4 different scenarios. Something else I wanted to bring up that I was asked to bring up yesterday and had an issue that came to our facility. There was a direct admit patient who was coming in for a gyno problem, and the patient had a change of condition, deteriorated somewhat en route here, and no notification was given to our ER that happened. And they wanted to take this patient to OBED, but that patient was 70 years old. So I'm not 100% sure that would be beneficial. And physically pushed around the doctor that was trying to stop them in the ER to see the patient. So if you have a patient that deteriorates en route to direct admit, first of all, you need to let the ER know that and stop in the ER. They may very well tell you to take them where you were heading to begin with, but it's up to that ER doc to take that few minutes just to look at that patient. If you're calling an IR and going, hey, I'm bringing initials, blah, 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 and you're aware of this patient, yes, we are. All right, but this patient is now deteriorated and we need to be seen in the ER, so need the doc close, so then they'll stop by. But to go to Union, to the OBED, that didn't need to happen. So just wanted to let everybody know that. I was asked yesterday if I would be able to tell everybody, and I literally got really lucky that we have meetings today, so we're able to tell them. So think that's everything I have. Does anyone else have anything? Brian, you got a couple things?
I just wondered, I'm gonna skip this one because that's probably
That's
my
fine.
fault.
Yeah.
Yeah. So our telespecialist docs, Doc was talking about strokes earlier, and we were talking about strokes and kind of the things that both ERs at regional and union want to see coming in. Our teledocs, and I sent it out to the EMS contact list leadership that I have, so hopefully they can maybe get that out to the crews. It's a really rather short. They're going to do it the second Wednesday, like every third month. I don't know. It's weird how they do that, but anyway, they're going to talk about kind of what they would like to see information wise from EMS, that sort of thing. They're going to be a real interesting. What they're trying to do is kind of give what they'd like to see and then start that conversation with EMS and go, okay, what helps you guys out when we talk about stroke alerts and things like that. So I got a couple, 3 flyers here if anybody wants one. Like I said, I did send it out to the EMS folks, the directors of the contact list I have. And that's, I think, all I got for the moment.
Nothing else. I would say thank you very much for coming. Have some more breakfast and have a great day. If you're online, take the quiz.